Hi, I'm Dr. Steve Sorden. Today I'm going to talk about selected diseases of swine, some of the most important ones that we see in our routine diagnostic work, as well as some of the more interesting ones. I'd like to thank Dr. Pat Halber from Iowa State's Diagnostic Lab, as well as Dr. Ted Clark from the University of Saskatchewan for some of the images I'll show you today. So let's now go to the first slide. And let's move on to the next one. Okay. All right. Okay, before we get started, I should talk a little bit about the stages of modern swine production. This is something that's changed over the last few years. And the trend now is to wean pigs as early as possible. Typically, pigs are weaned at 3 weeks of age, although certainly there are producers that are weaning as early as 2 weeks of age. The primary point of weaning at early is so that animals encounter pathogens when they still have maximal maternal immunity. From 3 to 10 weeks, most pigs are in the nursery, so this is the nursery phase of production, and then they move to the finisher until they reach market weight at approximately 120 kilograms, and this varies from country to country. In some production units, they have a separate grower that is where pigs go for the first portion of this 10 to 26 week period, and so this is often referred to as grow finish. One of the important aspects of raising such large numbers of animals in a confined space is that we find that within these large units there are subpopulations of pigs that will vary quite a bit in the extent of their immunity to various pathogens, and so even though they may have been farrowed in the same barn and moved to the same nursery as a group, there will still be quite a variation in the immune and infection status of these pigs, and that allows disease problems to arise. Let's begin with PRRS, Porcine Respiratory and Reproductive Syndrome. This is easily the most important infectious disease of pigs in the U.S. today. PRRS is an arterivirus, and the arteriviruses are single-stranded, positive, enveloped RNA viruses. This family includes PRRS, equine arteritis virus, simian hemorrhagic fever virus, as well as lactate dehydrogenase elevating virus. All the arteriviruses replicate in macrophages. They have a fairly high degree of genome plasticity, and they cause asymptomatic persistent infections as well as severe clinical disease. As I said, PRRS is the most important swine disease in the U.S. This is not true in Europe, where the strains of PRRS in Europe are in general less virulent than those in the U.S. PRRS appeared in North America in the late 80s and has become widespread. This is a 50 to 65 nanometer viral particle. It's heat and pH labile, so that it's not easy to isolate, and autolyzed tissues will not be good candidates for viral isolation. PRRS fits the quasi-species concept in that it's an RNA virus, so copying of that genome has low fidelity, and this generates a variety of strains that vary greatly in sequence, and they vary greatly in virulence. And these different strains are different antigenically, and cross-protective immunity can be very poor. If you vaccinate pigs with a strain that is very different from the strains that they will encounter naturally, those vaccines will not work. PRRS is transmitted primarily by direct contact. It's a highly infectious virus, which means only a small number of viral particles are required to establish an infection, but it's not highly contagious. In other words, it spreads slowly through units, and this can be a problem if one is trying to intentionally expose a group of pigs to PRRS. This may not happen easily. Transplacental infection transmission certainly occurs, and we'll talk more about that later. Semen has been a source of infection for many herds that were PRRS negative, brought in PRRS positive semen and had major problems. Whether PRRS is efficiently transmitted via aerosol is somewhat controversial. If it does occur, it's over a fairly short distance. PRRS replicates in macrophages. That's the primary cell type that you'll find it in. At the site of infection, spreads to regional lymph nodes and is disseminated throughout the body. This is truly a systemic infection, but the organs that are most affected are lungs and lymphoid organs. There's also some replication in smooth muscle cells and endothelial cells. It crosses the placenta of viremic sows and results in persistently infected pigs. That is, pigs from which virus can be recovered for greater than 6 months following infection. This is a real problem and allows this virus to maintain itself in herds. Now, this persistent infection should not be confused with the persistent infection that we see in cattle with BBD virus. These pigs are not infected before they're immunocompetent, but rather these pigs mount an immune response to PRRS, but it does not successfully clear the virus. Clinical signs in pregnant sows, this is reproductive and respiratory syndrome, and as the name says, abortions, mummifications, stillbirth, weak neonates. And some strains are virulent enough that they will actually induce fever and dyspnea in sows. Others, the sows will remain clinically normal. Neonates can be born sick, and they'll be febrile, dyspneic, and eventually die. This moves into the nursery with similar clinical signs, but usually with death is due to secondary bacterial infections, particularly Streptococcus suis, meningitis, and septicemia. And then in grow-finished pigs, PRRS is a key component of the porcine respiratory disease complex, which I'll talk about later on. Gross lesions of PRRS. PRRS induces an interstitial pneumonia, and so the lung is grossly mottled, tan, it's rubbery. The distribution can be extremely variable, from the typical diffuse change we expect of an interstitial pneumonia to, in some cases, predominantly a cranioventral pneumonia. And often the cranioventral portions of the lungs are the best places to sample for finding the most severe lesions and for detecting antigen. So that's somewhat unexpected for an interstitial pneumonia. Lymph node enlargement. You can see markedly enlarged lymph nodes throughout the body, but particularly the thoracic and iliac nodes. Fetuses in general do not have lesions that are very specific. We often see edematous umbilical cords that have zones of hemorrhage. This will be seen in fetuses with PRRS, but can be seen in fetuses aborted for other causes. And mesocolonic edema, again, has been associated with PRRS, but is a non-specific lesion. Here is a grossly normal porcine lung. It's an open thoracic cavity, nice salmon-colored lungs. They're well collapsed. And this contrasts nicely with a lung from a pig that's been experimentally inoculated with PRRS virus. Notice the lung does not collapse well. We see this caudal aspect of the caudal lung lobe, which we would normally not expect to see, and the lung is diffusely tan to mottled tan and has a rubbery feel. Lymph nodes are markedly enlarged. This is an iliac lymph node, and these are frequently very enlarged due to severe lymphoid hyperplasia. Microscopic lesions, the lung is the most important one. There's a mild to moderate type 2 pneumocyte hyperplasia. Alveolar septa are thickened by mononuclear inflammatory cell infiltrates. Alveoli contain mixed leukocytes or mixtures of necrotic to fibrinonecrotic debris, and that's a fairly characteristic PRRS lesion. PRRS antigen is present in alveolar macrophages, but also in intravascular macrophages, and experimentally it's been shown that these intravascular macrophages in PRRS-infected pigs no longer perform the normal clearance of circulating particles that normal intravascular macrophages perform, so there's good evidence of damage to those cells. Airway epithelium is unaffected, and so if we have a lung that's only infected with PRRS, we would not expect to see any changes to bronchiolar or bronchial epithelium. Here's a lung from a clinical case of PRRS. This is non-perfused lung, so requires us to distinguish the microatelectasis from the true thickening of alveolar septa with infiltrating mononuclear cells. Here's a higher power view. Notice this fibrinonecrotic debris within the alveolar spaces. This is a pretty characteristic PRRS lesion, and again, the thickened alveolar septum. A higher power view, minimal exudate here, but certainly some mild type 2 pneumocyte hyperplasia, mild to moderate, and macrophages infiltrating the septa. And here we have mixtures of a variety of cell types, macrophages, lymphocytes, plasma cells, as well as some necrotic debris. So pretty characteristic PRRS lesions. Immunohistochemistry for PRRS antigen is a good diagnostic tool, and it reveals that we have antigen-positive macrophages within alveolar spaces. The number of positive cells can vary tremendously, and it's often necessary to examine 4 to 5 sections of lung before we find a cluster of positive macrophages. In other cases, with more severe lesions, we'll find just tremendous amounts of antigen. So it's very variable. More microscopic lesions, severe lymphoid hyperplasia in tonsil, Peyer's patch, wherever there's lymphoid tissue. Mild to moderate lymphocytic to lymphohistiocytic myocarditis. We often see some perivascular mononuclear cell infiltrates in myocardium. In the brain, it's very common to see a small amount of cuffing and then a lymphohistiocytic rhinitis. Vasculitis, remember this is an arteriovirus, so we would expect to see some vasculitis. It's not as common as one would hope, but it certainly can occur in a variety of tissues and can be seen particularly in fetal tissues. However, it's important to remember that most fetuses that are aborted due to PRRS lack lesions, and so you may wait a long time before you see a nice diagnostic lesion. Here's a typical myocardial infiltrate, just nothing particularly unique about this, just some mononuclear inflammatory cell infiltrates in the myocardium. We often see a small amount of inflammation in brains of pigs with PRRS. In some cases, there are reports of central nervous clinical disease associated with PRRS, in which the only pathogen that can be identified in these brains is PRRS virus. This is an example of one of those cases where we have some moderate numbers of mononuclear cells around vessels, diffuse gliosis, and we often will also see nodular gliosis. And it's important to do an immunohistochemistry on these, demonstrate the positive mononuclear cells, and there are neurovirulent strains of PRRS that will occasionally occur. This is a pulmonary artery from a fetus. It was aborted due to PRRS virus infection, and you can see that the arterial wall is thickened due to infiltrating cells. It's a nice, very characteristic lesion of PRRS infection, but it's rare, and whether we need to just cut in more pieces of lung, I think it's just the finding the right fetus is the key, and there's really no way to do that other than by chance. So diagnosis of PRRS, immunohistochemistry is a very good tool, as I noted before, but it's fairly insensitive. Virus isolation, you'll note, was discussed in the handout, and this is done on mark cells. One of the best samples to submit for virus isolation is bronchoalveolar lavage fluid that is performed on freshly euthanized pigs. Just merely instilling some isotonic fluid, saline, lactated ringers. As long as it's isotonic, instilling and then aspirating from the entire lung or a portion of lung, depending on the size of the pig, and then freezing this sample and submitting it to a laboratory. When it gets to the laboratory, it's frozen and thawed several times and then applied to cells. This is a very nice sample, doesn't require any tissue homogenization. Certainly tissue homogenates can be used. Another excellent sample to submit is serum from pigs that have not received colostrum. Once they've ingested colostrum, the maternal antibody will bind the virus and greatly decrease the chances of isolating the virus. But if you can get serum from weak-born pigs that are not strong enough to have ingested colostrum in an abortion outbreak, that sample is much better than looking at a bunch of aborted fetuses from which virus will never be isolated. PCR is a very useful tool for diagnosing PRRS. It's used in a variety of samples: serum, semen, which is an important sample to test, and also we've used it on thoracic fluid from porcine fetuses and has proven fairly successful in our hands for detecting PRRS. So I'd like to leave PRRS now and move on to a newer disease, post-weaning multisystemic wasting syndrome, or PMWS. This disease was first noted in the late 1990s in Saskatchewan and Alberta in Canada. These occurred in high health herds that are PRRS seronegative. Clinical signs were weight loss, dyspnea and pallor, and less commonly diarrhea and jaundice. And pigs were in the 4 to 14-week-old phase, so basically the nursery and early part of the finishing period. And morbidity and mortality was typically 5 to 20%. Mortality of each pig was much higher than that. And this disease has since been described basically throughout the world. Okay, PMWS has been associated with porcine circovirus, and just a bit about circoviruses. These are single-stranded DNA viruses that have a circular genome. They're the smallest known animal viruses. Porcine circovirus is only 17 nanometers in diameter. They're non-enveloped, they're resistant to heat and low pH. These are comparable to parvovirus in their resistance to the environment. And the family Circoviridae includes several members, including those listed here. The virus we're concerned with is type 2 porcine circovirus, which was first isolated and characterized in 1997. It's consistently present in tissues of pigs with PMWS, and it's markedly different from PCV1. PCV1 is a cell culture contaminant that's been known about for over 20 years, but this type 2 porcine circovirus has less than 80% nucleotide sequence identity and very low serological cross-reactivity, so it's quite a different virus. PCV2 and PMWS, and there's certainly some controversy out there about whether Koch's postulates have been satisfactorily fulfilled for this disease. What we do know is that PCV2 is consistently demonstrable in PMWS lesions, and inoculation of PCV2 induces PMWS lesions that are not, it induces them, but they are not as severe as those that are seen in field cases. If you give porcine parvovirus or PRRS with the PCV2, the disease is more severe and is more comparable to field cases. And in our caseload, Midwestern U.S., most of our cases, greater than 60%, are co-infected with PRRS. PCV2, how is it transmitted? Rigorous studies in the field have not been performed, but certainly intranasal or intravenous inoculation experimentally will induce disease. Most likely it's transmitted via direct contact and fomites. It's highly resistant to inactivation, similar to parvovirus. And certainly if the biosecurity isn't up to snuff, it will survive in pig units. It can also be transmitted vertically, and abortions associated with PCV2 have been reported, especially myocarditis in those aborted fetuses. So if we encounter porcine fetuses with myocarditis, we certainly want to look for PCV2. We want to look for PRRS as well, but this has been reported in PRRS negative herds. Pathogenesis. It replicates predominantly in mononuclear phagocytes and often induces cytoplasmic inclusion, but antigen or genome have been detected in a variety of epithelial cell types as well as fibroblasts and apparently smooth muscle cells. Interestingly, in epithelial cells, the inclusions are predominantly intranuclear. Replication is favored in rapidly growing cells, and it in vitro requires 2 host cell cycles to replicate. Parvovirus also requires cell replication, but it only requires 1 host cell cycle. PCV2 requires 1 cycle just to get into the nucleus and another to express the S-phase proteins that it needs to replicate its genome. Clinical signs in our experimentally inoculated animals start to show up between 10 and 14 days post-inoculation and extend for 3 to 4 weeks. Here's just some information from a series of 80 cases that we looked at in a couple years ago, and these trends have certainly continued till today. Most of our cases, somewhat different from the Canadian story, most of our cases are pigs that are greater than 50 pounds or 10 weeks of age. So most of our cases occur in early grow finish. We rarely see PMWS in 4 to 5 week old pigs that have just been weaned. Pigs, if we have a history of failure to thrive in 4 to 5 week old pigs, it's hardly ever PCV2 PMWS. More likely those situations we need to think about PRRS, which can certainly cause ill thrift in pigs that age, and the other thing is management difficulties in getting these young pigs adapted to solid food. For clinical signs, most common is respiratory disease, expiratory dyspnea, thumping, that's what the producers call this, failure to thrive, diarrhea, and a small percentage were sudden deaths. 80% of the herds affected in this series had 2 to 15% morbidity. So this is not a devastating disease that affects large numbers of pigs, but it affects a subpopulation that does not respond to any type of therapy and becomes very frustrating for the producer. Here is a dramatic example. These pigs were all entered this finishing unit at the same time, at the same weight, and this pig with PMWS has a rough hair coat and a prominent vertebral column and is obviously about half the size of his cohorts. The lesions of PMWS. Gross lesions are non-diagnostic, and although one can suspect PMWS grossly, we need microscopic examination to confirm it. Lungs are rubbery, non-collapsed, mottled tan to gray, very similar to PRRS. Lymph nodes are enlarged, very similar to PRRS, but the difference ends at the gross level in that in PRRS, lymph nodes are enlarged due to lymphoid hyperplasia. In PMWS, lymph nodes are enlarged due to replacement of the lymphoid tissue by macrophages, by granulomatous inflammation. And it's really the hallmark of this disease is depletion of lymphoid organs. We may or may not see intracytoplasmic inclusion bodies. Lymphohistiocytic to granulomatous inflammation can occur in lymphoid tissues, but also in lungs and liver, kidney, pancreas, intestine, a variety of tissues. Here's a nice case of PMWS. This pig was also co-infected with PRRS. We have extremely non-collapsed lungs that are diffusely rubbery and mottled, and also some cranioventral consolidation associated with secondary bacterial pneumonia. The other thing to note here is these tremendously enlarged paratracheal lymph nodes. Here's a histologic section of a severe interstitial pneumonia. These interalveolar septa are markedly thickened and there's abundant debris within the alveolar spaces. So how do we tell this from PRRS? Well, the answer is we need more tests to do it. We can't do it on the morphologic basis, but in general, PMWS pneumonias are more severe than PRRS, those induced by PRRS alone. And here are three representations from an experimental inoculation trial we did. This is control lung. normal alveoli. This pig received PRRS virus, but not circovirus. We have a mild to moderate interstitial pneumonia, as we talked about earlier, and this is from a pig that received both porcine circovirus and PRRS. And there's more severe thickening, more severe exudation. But it's certainly a continuum, and we can't call it just on the basis of morphology alone. Just a higher view demonstrating the severe type 2 pneumocyte hypertrophy and hyperplasia and the abundant exudate within the alveoli. This is in situ hybridization for PCV2. It's a low power shot just to demonstrate the tremendous amount of PCV2 genome that is often present in these affected lungs. Note in this case, a small bronchus up here is basically unaffected, but that's not always the case. A pattern that we frequently see is for there to be large amounts of antigen or genome, depending on whether we're using in situ hybridization or immunohistochemistry, in the tissue around airways. And then it's occasional antigen-positive epithelial cells with minimal changes to the epithelium. In other cases, we do have epithelial lesions. We get attenuation of the epithelium with some irregular hyperplasia and then some mild peribronchial fibrosis. And here we have an in situ hybridization demonstrating the attenuated epithelium, scattered positive cells, and the numerous positive cells in the tissue around this bronchiole. This is an experimentally inoculated pig that received only porcine circovirus. Again, positive cells around the airway and positive epithelial cells. So this is a virus that does replicate in bronchial epithelium. We often see lesions that are even more striking than that. This is from a bronchus. We have erosion of the bronchial epithelium, and we end up with these isolated arrays of intact bronchial epithelium. Here's a dramatic example. We have an obliterative bronchiolitis. The lumen is obliterated by fibrous tissue and macrophages, and then we can see these little clusters or rafts of remaining bronchial epithelium, bronchiolar epithelium. It's a fairly unique lesion. I have not seen this in a pig in which porcine circovirus was not demonstrated. And just one more bronchus, this occurs in both bronchi and bronchioles, attenuation and erosion of epithelium and replacement by fibrous tissue. Lymphoid depletion is what I'd like to demonstrate next. This is really the hallmark lesion of PMWS. This is a porcine tonsil with the epithelium at the top of the image. Numerous, well-developed lymphoid follicles. This is a normal porcine tonsil, and this contrasts with a tonsil from a pig with PMWS. It's a severe example, but there are no follicles left, very few lymphocytes, and a lot of eosinophilic fibrous stroma in the background. Another variation that we see is in replacement of these lymphoid follicles with macrophages in multinucleate giant cells, so a granulomatous tonsillitis. We do in situ hybridization on these severely affected tonsils. We find large numbers of genome-positive cells. So the severity of the lesion and the number of positive cells is fairly well correlated. Here's the problem that those of us that think PCV2 causes this disease have. This is a tonsil from a normal pig, histologically normal, but we find circovirus genome in follicular centers, and you can find this occasionally in normal pigs that are submitted for other disease or from tonsils from pigs taken at slaughter. And so infection with porcine circovirus is much more common than disease. In fact, serologically, most pigs in most surveys have been positive. So seropositivity has no relationship with disease. Here's spleen. These used to be periarterial or lymphoid sheaths, and they've been replaced largely by macrophages and abundant circovirus. This is an example of a depleted lymph node. Remember that porcine lymph nodes are reversed from other mammals, and what would be the cortex is in the middle of the node, but there are no discernible lymphoid follicles. Granulomatous lymphadenitis with lots of multinucleate cells and macrophages is not an uncommon finding. And again, these will be positive for circovirus. So one more example of lymphoid depletion. This is porcine Peyer's patch. There's the villi in the ileum and the Peyer's patch, the lymphoid follicles in the submucosa. And this is from a pig with PMWS. This slide is from a pig with PRRS. And so when we see tremendously hyperplastic Peyer's patch or other lymphoid tissues, we always want to think about PRRS virus. Certainly there are a variety of other reasons for this. And again, depleted Peyer's patch with lots of positive cells, both in the Peyer's patch and throughout the lamina propria. And these pigs' diarrhea can certainly be a presenting sign in cases of PMWS. Here are the inclusion bodies in the middle of a Peyer's patch. These vary quite a bit. Here they are. They're globular, intracytoplasmic clusters of variably sized inclusions that vary from eosinophilic to amphiphilic to basophilic. And here's another example. These are more amphiphilic, globular, intracytoplasmic inclusions. But certainly we don't always see these, and probably less than half the cases in which abundant circovirus antigen can be detected are there discernible inclusion bodies. There's a slide borrowed from Dr. Ted Clark. This is an electron micrograph of an inclusion, and it's consists of arrays of viral particles. These are only 17 nanometers, so they're just about at the limit of resolution of TEM. Livers can be severely affected by PMWS, and we occasionally get pigs that are severely jaundiced, and they have a wide spectrum of liver lesions. I'll just show a couple examples. Here we have disruption of hepatic plates with lipidosis. Even livers that are less severely affected than that can have abundant genome, both within hepatocytes and Kupffer cells. And here's a high-power view showing a nice example of a severe hepatopathy, loss of hepatocytes, some infiltrating mononuclear cells, and some extremely hypertrophied hepatocytes. And the final tissue I'll show you is pancreas. Not consistently, but occasionally we see pancreatic lesions, infiltrates of mononuclear cells, and scattered apoptotic or acinar epithelial cells that have undergone coagulative necrosis. Diagnostic criteria for PMWS. These are criteria that I have proposed, and no one has argued with me yet. I think we need to have clinical signs of wasting or failure to thrive with or without the other clinical signs. Microscopic lesions, those that I've shown you, the depletion of lymphoid organs and or lymphohistiocytic to granulomatous inflammation in any organ. And then we need to demonstrate circovirus infection within the lesions. And the implications of these criteria are the following. First of all, clinical signs are not diagnostic. There are lots of causes for pigs to do poorly in a nursery or grow finisher. Gross lesions are not diagnostic. And PRRS especially, and salmonellosis to a lesser extent, can look just like PMWS, big lymph nodes, interstitial pneumonia. And circovirus infection does not equal PMWS. PCV2 infection is much more common than this disease syndrome, and exactly what factors trigger the development of this disease have still not been entirely sorted out. We certainly know that parvovirus and or PRRS infection, co-infection with PCV2 will increase the severity of this syndrome. But how this all happens in the real world is still an open question. So now I'd like to move on to a related syndrome. We think it's related. This is a much less common and less economically important disease than PRRS or PMWS, but it certainly is a striking lesion. And that is dermatitis and nephropathy syndrome. This has also been called cutaneous and systemic necrotizing vasculitis, or systemic necrotizing vasculitis and glomerulonephritis. This is a disease of grow-finished pigs predominantly, and the cause is unknown. What we do know is that the pigs are usually infected with circovirus and or with PRRS. But the problem is that the lesions and the antigen-positive cells are not well correlated. Clinical signs: you see coalescing red-purple macules and papules that are usually most severe over the hind limbs and perineum, but they may be generalized. Some of the pigs will keep eating and their skin lesions will progress and resolve. Others are found dead after a brief illness. Presumably those that get better did not have severe renal disease. This usually occurs in a very low percentage of pigs in a finisher, less than 0.5%. But it certainly is striking and causes concern on the part of producers when it does occur. And here is a gross photograph demonstrating these macules. These represent cutaneous infarcts, and they're nicely demarcated from the surrounding skin. Sometimes it's just over the hindquarters, the rest of the body looks all right. In other cases, it is generalized and it coalesces. The entire perineum in this pig is one large infarct. So the skin lesions are the most striking gross lesions. The kidneys are frequently markedly enlarged, pale and covered with petechia. Lymph nodes are often very enlarged. Histologically, those skin lesions are hemorrhagic cutaneous infarcts, and the dermis and subcutis have a leukocytoclastic vasculitis that I'll show you in a minute. And vasculitis can be found in vessels in the skin, in the kidneys, in the synovium, in the stomach, but predominantly in skin and kidneys. The other thing is that frequently there will be some lymphoid depletion or other lesions suggestive of PMWS, and PRRS or circovirus can be demonstrated. This is actually from the ear of a pig with PDNS. Here is the infarcted epidermis and subjacent dermis. This is viable epidermis. And here are the necrotizing the vessels affected by necrotizing vasculitis, and there's a large amount of edema in the adjacent tissues. In a higher view, this is a typical leukocytoclastic vasculitis. The vessel walls are thickened and infiltrated with neutrophils, but predominantly just with karyorectic debris. Here's a kidney from a pig with PDNS, a low power magnification view. Notice there's protein casts and scattered tubules. Many of the tubules are dilated. There are also some infiltrates of mononuclear inflammatory cells. Porcine circovirus in PDNS, in PMWS, we often see lymphohistiocytic to granulomatous interstitial nephritis. But this is a different lesion. This is a glomerulonephritis in which the Bowman's spaces are severely distended with fibrin and proteinaceous fluid. The glomeruli themselves are hypercellular, often infiltrated by neutrophils and occasionally necrotic. So it's a severe acute glomerulonephritis. When we look for porcine circovirus antigen, sometimes we find it predominantly within renal tubular epithelial cells. And you think you can make out that the inclusions are predominantly, or the genome is predominantly intranuclear rather than diffuse throughout the cytoplasm. But more commonly, the only place that Circo is demonstrated is within lymphoid tissues. And here's Peyer's patch. This is an immunohistochemical preparation, lots of positive cells. So the jury is certainly still out on the cause of this syndrome. It would certainly fit with an immune complex mediated disease, but exactly to what antigen the immune complexes or to what antigen the immune response is directed and what the immune complexes would consist of is unknown. No one has proven that immune complexes are present in this disease. So hopefully in the next few years this will be sorted out, but it certainly is associated with PRRS or circovirus, and usually both, infection with both agents. Okay, the next disease I'd like to talk about is swine influenza. Swine influenza is certainly not a new disease, one of the oldest swine diseases, caused by SIV, swine influenza virus, type A influenza virus, for about 80 years, since around 1918, the great influenza pandemic in humans. The predominant subtype in North America has been H1N1, and just to review, the H stands for the hemagglutinin and N stands for the neuraminidase. And influenza viruses are typed on the basis of their H1N1 genes and antigens. So for about 80 years, H1N1 has been the predominant strain. Suddenly, in 1998, H3N2 influenza hit the United States and spread rapidly. First cases in North Carolina, Texas, then it arrived in the Midwest and has basically gone throughout the country. Since the hemagglutinin are the most important protective antigens involved in inducing an immune response, H1 and H3 happen to be two of the least closely related. They are have only 25% homology. So basically, immunity to H1N1 offered no protection against H3N2. Hence, pigs that were well immunized against H1N1, and there's been a vaccine for several years, these pigs were totally susceptible to H3N2, and you can predict the results. There were many severe outbreaks of influenza. Now, just this year, in the last couple months, an H1N2 virus has been isolated. So SIV is undergoing its antigenic shift as occurs in humans and other species that get influenza. SIV is transmitted by direct contact. It is both highly infectious and highly contagious. It replicates in respiratory epithelium throughout the respiratory tract, in nasal mucosa, trachea, bronchi, bronchioles, and this is a fast virus. We get clinical signs within 24 hours of inoculation, but by about a week it's gone. And systemic infection basically does not occur. There are a few reports in the literature of fetuses in which SIV was detected, but those are rare exceptions. Basically, this is a virus that stays in the respiratory tract, comes and goes. So it's in marked contrast to the other two viruses we've talked about today, PRRS and PMWS, both of which infect macrophages, become systemic, and cause fairly long-term, if not persistent, infections. A classical epizootic involves high fevers, coughing, anorexia in a high percentage of the herd. Very high morbidity disease, but a low mortality. With the exception of when H3N2 first hit, we see fewer and fewer epizootics, and it is most important now as a component of porcine respiratory disease complex. Pregnant sows that encounter influenza virus can abort, and this is due to the fever, and this is systemic inflammatory response rather than a specific effect of the virus. The lesions in pigs with SIV, grossly there's a multifocal to coalescing red-brown cranioventral pulmonary consolidation, often with a fair bit of hemorrhage. You're not likely to see pure SIV, but occasionally you will, and it has a fairly characteristic gross lesion. Histologically, it induces a lymphocytic bronchointerstitial pneumonia with necrotizing to proliferative bronchitis and bronchiolitis. So when we see bronchiolar and bronchial epithelial damage in pigs, our first thought is SIV. There's often fairly striking alveolar hemorrhage, and secondary bacterial bronchopneumonias are common. Here's an experimentally inoculated pig. Notice the cranioventral tan to brown consolidation, which appears to result from coalescence of these multiple similarly affected foci. But as I said, it's unlikely that you will frequently encounter SIV by itself. Histologically, this is the lesion. This is a bronchiole. Notice the nice columnar epithelium is absent, and it's replaced by a very attenuated epithelium. These epithelial cells are doing their best to cover the denuded basement membrane. There's necrotic debris and inflammatory cells in the lumen, and the bronchiolar wall is thickened by infiltrates of mononuclear inflammatory cells, and these extend out into the adjacent alveolar septa. So a bronchointerstitial pneumonia. This affects both bronchioles and bronchi. This is a small bronchus, and if we go to a higher magnification, we can appreciate we're in the subacute phase of SIV with marked hyperplasia of bronchial epithelium, multi-layered epithelium. Also, some mononuclear inflammatory cells have infiltrated the epithelium as well. So when you see necrotizing to proliferative bronchitis and bronchiolitis, usually dealing with SIV. Occasionally we'll get a severe tracheitis with SIV. This is the remaining epithelium. It's multifocally eroded with hemorrhagic exudate in the lumen and severe hemorrhage in the tracheal wall. Probably a lot of this is due to the severe coughing associated with SIV infection. Diagnosis is fairly straightforward. The lesions can certainly be suggestive, but it's nice to demonstrate antigen, FAs, ELISA. There's an antigen capture ELISA that's used. It's made for human influenza, and these kits can also be used to detect SIV. Immunohistochemistry is the tool we probably use the most. We use a monoclonal antibody to a nucleoprotein, and so this detects both H1 and H3 viruses. We're also currently working on a differential test to distinguish H1 and H3. Virus isolation on live pigs is best done using nasal swabs and dead pigs' lung tissue from acutely affected animals. As in any attempt to isolate virus from a live animal, we always want to choose the most acutely affected pigs, the ones with clear nasal discharges and high fevers. These nasal swabs can also be subjected to PCR, as can lung, but in our experience to date, the direct PCR has not been as successful as has the virus isolation from these samples. PCR is used to subtype viral isolates, and virus and SIV can be isolated in embryonated chicken eggs, which is what we use, or other laboratories use MDCK cells. Serology. Within a week of infection, the hemagglutination inhibition titers are up to 1 to 80, and within 2 to 3 weeks, they're greater than 1 to 640. And then these titers wane over the next several months. There is basically no cross-reaction between the H1N1 and the H3N2 strains, so it's fairly easy to use serology to distinguish which subtype pigs were infected with. One caveat is that if you're going to do serology for both strains, we need to make that decision up front, because heat and activation of the serum is required for detection of H1N1, but it is detrimental to detecting antibodies to H3N2. Fetuses are of no value in diagnosing influenza virus infection, and when we have outbreaks of abortion in sow herds, practitioners suspect that this might be influenza. We're not going to find the virus in the fetuses. The best way to diagnose influenza as a cause of an abortion storm or a mini storm is convalescent serology on the sows. Here's an immunohistochemical test done on a bronchiole. Notice the numerous positive epithelial cells, as well as positive as antigen within the bronchiolar lumen. The most strikingly positive lungs are those with just mild peribronchial mononuclear inflammatory cell infiltrates and minimal bronchiolar epithelial changes. Some of these airways will be entirely lined by antigen-positive cells. Once the inflammatory response gets going, cells undergo necrosis. Within 3 to 4 days post-inoculation, antigen-positive cells can be few and far between. So we need to catch these pigs early. Another slightly unique feature of SIV is that the antigen is predominantly intranuclear. There's also some intracytoplasmic antigen, but it's predominantly intranuclear and consistent with the replication of orthomyxoviruses within nuclei. So that's influenza. Let's move on to the other classic cause of pneumonia in pigs, Mycoplasma hypopneumoniae. Mycoplasmal pneumonia is caused by M. hyo. Enzootic pneumonia refers to mycoplasmal and secondary bacterial pneumonia. We almost never see M. hyo by itself. It is usually secondary bacterial infection by predominantly Pasteurella multocida type A. Strep suis is a close second. The porcine respiratory disease complex, in most cases, this refers to respiratory disease in pigs in the first part of grow finish, and in most cases at the present time PRDC results from an interaction of PRRS, M. hyo pneumonia, and secondary bacteria. However, SIV is certainly a component of PRDC in some units, and porcine circovirus should be added to the list as well. So it's a mixture, and it's a grossly non-specific lesion of cranioventral consolidation, interstitial pneumonia in the caudal dorsal lung, and it requires histopathology and other ancillary tests to sort it out. Pathogenesis. M. hyo attaches to cilia on respiratory epithelium, and that's about as far as it gets. It does not invade epithelial cells, but by attaching to the epithelium, the cilia, it reduces mucociliary clearance, causes loss of cilia. It alters alveolar macrophage function by yet poorly understood mechanisms, and most importantly, it induces lymphoproliferation. It's a non-specific mitogen for lymphocytes, and this is what causes the pronounced peribronchial or perivascular lymphoid cuffs that are characteristic of mycoplasmal pneumonias. M. hyo facilitates P. multocida infection, and thus resulting in enzootic pneumonia. And for several years, the association between M. hyo and PRRS has been noted clinically, but it has been difficult to experimentally reproduce a synergism between these two organisms. Recently, MHIO-PRRS synergism has been documented, and curiously, it appears that MHIO increases the severity of PRRS, whereas previously it had been thought that things were the other way around, that PRRS would cause mycoplasmal pneumonia to become more severe. Clinical signs of PRDC, or mycoplasmal pneumonia: predominantly coughing and poor performance in grow-finished pigs. This has been referred to in the lay literature as the 18-week wall. When pigs get to be 18 weeks of age, frequently we get maximum development of these lung lesions and they stop growing. Grossly, we have lungs that have sharply demarcated cranioventral tan purple consolidation. Bronchi contain mucopus or excessive mucus. If PRRS is present, then there is an interstitial pneumonia in the caudal dorsal lung. But this can be difficult to be sure of grossly, because even without PRRS, lungs with mycoplasmal pneumonia will often remain inflated due to the airway obstruction. This is an example of an experimental MHIO inoculation. This is as severe as a lesion as Dr. Halber and collaborators were able to induce just with Mycoplasma pneumonia by itself. We have these multifocal areas of consolidation. If pigs were co-infected with PRRS, we got a more striking lesion. We have larger areas of consolidation, as well as the more diffuse interstitial pneumonia expected with PRRS. This is a more typical clinical case, field case of mycoplasmal pneumonia, sharply demarcated cranioventral consolidation. These are rubbery to firm lungs, and if we cut this portion off, the airways would be filled with mucopus. Microscopic lesions: the hallmark is the lymphohistiocytic bronchointerstitial pneumonia with marked hyperplasia of the balt, the bronchus-associated lymphoid tissue. Typically, alveoli contain proteinaceous fluid and fairly loose aggregates of macrophages, plasma cells, and neutrophils. It's a mixed inflammatory cell population, remarkable numbers of plasma cells in many of these cases. PRRS co-infection induces more severe type 2 pneumocyte hyperplasia and more pronounced infiltrates in the alveolar septa. So here's an example of mycoplasmal pneumonia in a field case. Very prominent peribronchial cuffs and exudate, predominantly suppurative exudate within the bronchial lumens. The adjacent alveoli contain proteinaceous fluid, inflammatory cells, and these adjacent inner alveolar septa are thickened. Closer view demonstrating the exudate in the lumen, the pronounced cuffing. Notice there is minimal damage to the epithelium. There are infiltrates of mononuclear cells or neutrophils within the epithelium, but the epithelium itself still consists of tall columnar cells. There's variable loss of cilia. Here's the cilia are remaining, but this can be a difficult call to make histologically, especially if there's any amount of autolysis. Higher magnification view of the exudate, plasma cells, macrophages, and occasional neutrophils, with some mild type 2 pneumocyte hypertrophy and hyperplasia. Diagnosis: certainly the severe balt hyperplasia is suggestive, and unfortunately still in many cases we're forced to make a diagnosis of consistent with mycoplasmal pneumonia. But we should be careful of overinterpreting these peribronchial and perivascular lymphoid cuffs, because certainly swine influenza can also induce that lesion, and especially in the resolving phase, we can have the epithelium that's been reconstituted and still be left with some fairly thick and prominent peribronchial or lymphoid cuffs, we don't want to incorrectly diagnose mycoplasmal pneumonia on that basis. It's far better if we can demonstrate the antigen via direct fluorescence on fresh lung, and this needs to be fresh because, as you're aware, the epithelial cells will slough with any degree of autolysis, and if there are no epithelial cells, there will be no antigen because it's on the luminal surface of the airway epithelium. Preferably, you want to submit large bronchi, and fresh tissue is critical. Immunohistochemistry has been of some use, but prolonged fixation, at least in our hands, appears to impede the sensitivity of this test. Its specificity is high, but the sensitivity is low. Direct PCR and tracheal bronchial swabs is used in many laboratories and is proven to be a fairly good way of detecting MHIO. Isolation is infrequently attempted. It requires very fresh tissue. These mycoplasmas are fragile organisms, and it's expensive. It's expensive because of the fairly complicated procedures that need to be followed in order to get away from Mycoplasma hyorinus, which is frequently present in these lungs and will easily overgrow the less hardy MHIO, pneumoniae. And so that's what makes culture attempts fairly pricey. There's usually no reason to isolate the organism anyway. Serology, there's an ELISA available for MHIO. It's fairly sensitive. However, it can take up to a month post-inoculation for pigs to seroconvert. So you can have well-developed lesions in seronegative pigs. But retrospectively, serology can certainly be a useful tool, especially in determining when in a given production unit MHIO infection occurs. Here's an example of a successful immunohistochemical test demonstrating the antigen on the surface, the luminal surface of this epithelium. I'd like to move on now to another classic respiratory disease of swine, porcine pleuropneumonia, caused by Actinobacillus pleuropneumoniae. There are 13 different biotypes. The most important, as far as causing severe hurt outbreaks, are types 1, 5, and 7. Viral co-infection is not required for severe disease. So in contrast to what's the case with, say, strep suis or Pasteurella multocida type A, we don't need an underlying viral infection. APP can cause severe disease just by itself. Has a variety of virulence factors, but the most important are the RTX toxins. These are pore-forming toxins that act in a similar manner to complement. APX1, APX2, and 3 have been identified. APX1 is the most important, and it's present in the most virulent strains of APP. Subclinical carriers, predominantly in the tonsillar crypts, are very common, and outbreaks can occur when a group is stressed either by environmental conditions or overcrowding or other management factors. And certainly viral co-infections can precipitate outbreaks of Actinobacillus pleuropneumonia, but they are not required. Clinical signs: this is typically a disease of grow-finish pigs. Often we see just per-acute deaths. We find dead pigs frequently with blood coming from their nostrils. Often we'll also see acute cases where there's coughing and fever. These pigs typically will not last very long, but occasionally some live long enough to develop chronic lesions, just poor performance, fairly non-specific. Grossly, there's a necrohemorrhagic and fibrinous pleuropneumonia that is very similar to the pleuropneumonia induced by Mannheimia hemolytica in cattle, and these are very similar organisms, and Mannheimia also has an RTX toxin. What's unique about porcine pleuropneumonia is, in contrast to Mannheimiosis in cattle, is that the lesions with APP are often centered on the hilar portion of the caudal lung lobe rather than cranioventral lobes. Now, often the lesions are fairly extensive, and so this hilar orientation is not discernible, but frequently it'll just be the hilar portion of the caudal lobe. Pigs that survive an acute APP infection may go on to slaughter, and at slaughter we may find chronic lesions which are characterized by sequestration of pulmonary parenchyma with fibrosis around the sequestered lung. And this is a very characteristic sequela of an acute APP. Here's a typical case of porcine pleuropneumonia. This is a more diffuse lesion. There's fibrin all over the surface of this lung with areas of hemorrhage. The lung is certainly non-collapsed and is fairly firm on palpation. And on section, we'd see large areas of parenchyma that are reddish to dark red to black and dry. Necrotic tissue is dry, and this organism induces extensive necrosis of lungs. Histologically, the lesions are fairly characteristic. There's zones of alveolar parenchymal necrosis, thrombosis, and hemorrhage. And these areas are frequently surrounded by dense bands of necrotic neutrophils, the oat cells, with very smudged fusiform nuclei. It's very difficult to be sure that these were in fact neutrophils when they were alive, but studies have repeatedly demonstrated that in contrast to being macrophages, as was once thought, these are neutrophils. Separative vasculitis is common, and again, this histologically, it's very similar to pneumonic Mannheimiosis in cattle. Probably the vasculitis is more common in porcine pleuropneumonia. Here's a low-power view. We have viable lung here, viable but certainly infiltrated by many leukocytes. We have necrotic parenchyma here, and at the junction we have a dense band of necrotic neutrophils. And here they are. These are the oat cells, very smudged nuclei, very difficult to see the typical neutrophil morphology. And these are neutrophils that have been recruited into the lung and then killed by this RTX leukotoxin that's punched holes in their cell membranes. Thrombosis is very frequently seen both within larger vessels and within alveolar capillaries. Severe edema, and then a dense band of the oat cells. How do we diagnose the disease? The lesion is fairly characteristic, and certainly routine bacterial culture will allow us to isolate the organism, usually in fairly high numbers. In most cases, we want to serotype or the isolates to determine if it's 1, 5, or 7, or if it's one of the less common and usually less important serotypes of APP. The serotyping can be problematic, and we get some strains that are untypable. In those cases, it's important to genotype the isolates and to determine exactly what serotype they fall into. In some cases, they're organisms originally identified as APP untypable will sometimes come back as Actinobacillus suis. Actinobacillus suis is a very closely related organism that also produces an RTX toxin and may induce gross lesions that are indistinguishable from APP. But it's an important distinction to make, because if a herd is supposed to be free of APP and we have pigs that start to die with lesions that certainly look like classic porcine pleuropneumonia, we want to make sure that those are caused by Actinobacillus suis, and in many cases they are. Actinobacillus suis microscopically usually induces an embolic pneumonia with prominent intralesional bacterial colonies, but even microscopically, Actinobacillus suis pneumonias can look virtually identical to those induced by APP, so isolation and serotyping or genotyping are critical. Here's an example of a typical A. suis embolic pneumonia. We have some congestion and edema, but then this focus of embolic pneumonia. At higher magnification, we see the bacteria in the center of the lesion, and then these necrotic neutrophils resulting from that RTX toxin surrounding the lesion. At this point, I'd just like to say a few things about the bacteria that induce septicemia in pigs. Certainly, pigs of all ages are frequently afflicted by systemic bacterial infections. In neonates, E. coli is probably the #1 cause of septicemia, but once those pigs are weaned and move into the nursery, E. coli is pretty rare. The primary agents that cause septicemias in nursery pigs are Streptococcus suis and Haemophilus parasuis. Both of these can induce a fairly broad spectrum of lesions. Predominantly, we're thinking of meningitis, polyarthritis, and polysericitis. Strep suis probably more commonly causes meningitis, but it can certainly cause polyarthritis and polysericitis. H. parasuis classically causes the polysericitis and arthritis, and of course that's known as Glasser's disease. But we certainly isolate H. parasuis from brains and Strep suis from joints and body cavities. In pigs that have been treated, it can be difficult to isolate these causative organisms, so submission of untreated pigs is crucial. Certainly, PRRS infection with other viral agents can predispose pigs to bacterial septicemias. Actinobacillus suis is an agent, I just mentioned it a minute ago, that can cause a pneumonia that's very similar to that induced by APP. A. suis is sometimes called the great imitator because it can also cause a septicemia with skin lesions that are very similar to those induced by Erysipelathrix rhusiopathiae. A. suis can cause lesions, cause deaths and disease in any age pig, from neonate all the way through grow finish. Salmonella cholera suis is classically a disease of grow finish pigs. Predominantly, it causes interstitial pneumonias, disseminated intravascular coagulation, cyanosis of extremities, but S. cholera suis can also cause polysericitis and occasionally meningitis and encephalitis. Erysipelathrix rhusiopathiae has been around for a long time, but it's certainly still with us in grow finish pigs and even in adult sows that have not, in whom immunity has not been maintained. So with modern methods of pork production, these agents are seen in different age groups than those with which they're classically associated, and with lesions that are not considered absolutely typical. So if we suspect a septicemia in a pig, it's important to institute bacterial culture attempts that are going to pick up all these different agents, because we are constantly being surprised with the unusual places that we find these. Now I'd like to talk about some enteric diseases. Clostridial enteric disease in pigs is something that's been changing in the last several years. Classically, we think of Clostridial enteric disease in pigs, we think of Clostridium perfringens type C and the necrohemorrhagic enteritis that's seen in neonates. This is characterized by necrosis and suppuration of the superficial or the entire mucosa of the small intestine, and those necrotic villus remnants are coated by large gram-positive rods, a very characteristic lesion, but it's a lesion that we see less frequently. Furthermore, in recent years, as more genotyping of Clostridial isolates has been performed, we have found that many of the Clostridia that are isolated from these typical cases of necrohemorrhagic enteritis are in fact Clostridium perfringens type A. So this clear-cut association of type C with this disease in neonates has been clouded recently. Another disease that we're seeing with more frequency is a non-specific neonatal diarrhea, predominantly in pigs less than a week of age, in which lesions are mild and nothing like the severe type C associated lesions, in which type A is the only Clostridia that is isolated, and many of these isolates are positive for beta-2 toxin. Beta-2 toxin is a recently described toxin of Clostridium perfringens type A that's been associated with diarrhea in several species, including horses and cattle. Another Clostridium that has come to the forefront more recently in pigs is Clostridium difficile, again with neonatal diarrhea, and or wasting, because some of these cases there has been very minimal diarrhea, but the pigs just waste away. Clostridium difficile makes two different toxins, the type A toxin, which is an enterotoxin, and toxin B, which is a cytotoxin. Clinical signs in the newer Clostridial enteric diseases, in addition to the sudden death we'd expect with type C, we also see just pigs with diarrhea, pigs with wasting. Gross lesions, certainly with type C, we expect the necrohemorrhagic to fibrinous enteritis. But with the type A or the Clostridium difficile, we just tend to see flaccid, fluid-filled intestines, pigs that are very thin and emaciated. And Clostridium difficile has been associated with very severe mesocolonic edema, with marked separation of the loops of colon in the spirocolon. Be careful with this mesocolonic edema because it is certainly not specific for Clostridium difficile, but it's a clue to look further. Microscopically, of course, we occasionally still see the fibrinonecrotic hemorrhagic enteritis, the type C associated lesion, but with type A we see surprisingly little. We will see sporulating Clostridia in the intestinal lumen, and then mild infiltrates of neutrophils in the villi. In some instances, we see discrete foci of villus tip necrosis and suppuration. In others, there's either just mild neutrophilia or no morphologic lesions at all. The only thing we find in some of these animals is lots of Clostridia in the lumen. Clostridium difficile, we frequently will see the colonic to mesocolonic edema and severe intense infiltration of neutrophils in the mucosa as well as in the mesocolon. Try to demonstrate some of these lesions for you here. This is a section of small intestine, and there is multifocal suppuration of the superficial villus epithelium. There's a higher power view to demonstrate that we've got attenuation of the villus epithelium and little exudate, predominantly neutrophils, spewing forth from these affected villi. Just a higher magnification to demonstrate the neutrophilic exudation and the damage to the superficial epithelium. This is what we would associate with Clostridium perfringens type A. In some cases, the villi are really unremarkable, nice, well-differentiated normal epithelium, but we've got all these large bacterial rods in the lumen, some of these cases we can see little circular structures within the bacterial rods that are consistent with sporulation. This would be an example of a Clostridium Difficile associated lesion. There's a mesocolon here, loops of colon here. Tremendous widening of this space. These should be very, very closely opposed normally, marked edema. And here is the mucosa. It's extremely edematous. The lamina propria is very edematous. It's infiltrated by neutrophils, and neutrophils are spewing forth from the surface of this colonic mucosa. So severe acute suppurative colitis. Diagnosis of these clostridial diseases require correlation of lesions with the appropriate bacteria. Type A, the lesions are, as I have described, isolation of Clostridia perfringens that preferably, if they contain the beta-2 toxin gene, that makes us feel better that this is a real disease caused by this organism. Some strains of Clostridium perfringens type A very likely have unknown virulence factors because we see the same lesions associated with both beta-2 toxin gene positive as well as beta-2 toxin gene negative Clostridia. Those who work in the field of Clostridia are convinced that there are as yet unidentified toxins produced by Clostridium perfringens that are lumped in the type A category, and that further work will identify those toxins and result in further divisions of this large group of organisms, because, as you're aware, Clostridium perfringens type A can be isolated from autolyzed intestines of just about any animal. So we really like to get euthanized animals in order to make this diagnosis. Clostridium difficile, there are certainly some characteristic lesions associated with it. Isolation of the organism is difficult, hence its name. Demonstration of toxin in colon is certainly supportive, and this toxin is very labile. You need to get fresh colon contents, freeze them at -70, or run the assay immediately, and there are ELISA assays to detect this toxin. One caveat is that I believe it's 40 to 50% of normal human infants have detectable Clostridium difficile toxin in their intestines. So the presence of the toxin does not always mean that disease will occur. So this whole field of clostridial disease in pigs as well as in other domestic species is something that will hopefully be sorted out in the next few years, because there's certainly many gaps in our knowledge. Spirochetal colitis, also known as colonic spiroketosis, is a syndrome that's people have become aware of in the last several years. The cause is Brachyspira pilosicoli, formerly Serpulina pilosicoli, formerly Treponema. These organisms have been reclassified very recently due to DNA analysis. Brachyspira pilosicoli is a weakly beta hemolytic spirochete isolated from porcine colons, and it's important that this be distinguished from Brachyspira hypodysenteriae, the cause of swine dysentery, which is a disease that we see less and less frequently, and for which eradication seems to be proceeding fairly well. Brachyspira hypodysenteriae is strongly beta hemolytic, so it's important to make this distinction in the laboratory. Pathogenesis, spirochetal colitis, the incubation is fairly broad, 3 to 16 days. The organism attaches to the microvillus border of the colon and invades between enterocytes, resulting in necrosis of this superficial epithelium. The typical clinical signs are poor growth, poor performance in the first part of the growth finishing period. With or without diarrhea, these pigs are not always noted to have a significantly loose stool. Mortality is rare, and this is certainly in contrast to swine dysentery. Gross lesions are really relatively mild. The mucosa is fairly unremarkable, although it can be reddened and variably eroded. I would say the majority of the cases, the mucosa looks good, but the contents are fluid to watery and often have what's a porridge-like consistency. Microscopically, this is a mild to moderate superficial erosive colitis with moderate glandular epithelial hyperplasia and often with some goblet cell hyperplasia. Typically, what we see in most clinical cases are spirochetes within dilated glands. Occasionally, and I think perhaps that should be rarely, we will actually see the characteristic lesion, which is arrays of spirochetes attached to the surface of the colonic epithelium. But this is a rare event, and the reason probably is that this is the initial site of attachment, and then after the damage is induced, we lose the superficial epithelium, and then the organisms are no longer on the surface but are within the mucosal gland lumens. Histologically, this is what we see. The hallmark lesion, if you're lucky, is this shaggy brush border. Hairy colon is what this is called in Pilosicoli. That's what the name means. There's increased numbers of mononuclear inflammatory cells in the lamina propria. Higher view here, here's the microvillus brush border, and here are the spirochetes attached to the surface. Silver staining will assist in the demonstration of this, and here we have these dense arrays of spirochetes attached to the surface. But again, you're more likely to find these in the lumen of dilated glands than you are out here. But when you find them here, it certainly is diagnostic. If you find them on the surface, you've got the diagnosis. More likely you're going to have to isolate the organism. It'll be weakly beta hemolytic. It's important to do PCR to definitively identify this as Serpulina pilosicoli. Differential diagnosis is swine dysentery, and unless you have those adherent spirochetes, the distinction between a mild case of swine dysentery and a moderate case of spirochetal colitis could be very difficult. So we need to get that organism, and we certainly don't want to miss swine dysentery so that we can find it and eradicate it. Diet has a great influence on the expression of both swine dysentery and spirochetal colitis. At least that's the experience in the field, and there's some experimental evidence for this. The more fiber in the diet, the less severe both of these diseases are. A disease that's interesting from an epidemiological standpoint, although not a terribly great clinical problem, is respiratory disease induced by porcine respiratory coronavirus. PRCV is closely related to transmissible gastroenteritis virus, which is a well-known disease of pigs, a coronavirus that causes a necrotizing enteritis. And both of these agents are closely related to canine coronavirus and FIP. As a matter of fact, monoclonal antibodies raised to TGEV, PRCV will detect both canine coronavirus and FIP. Antigenically, this family of coronavirus is distinct from porcine epidemic diarrhea virus, which is a coronavirus of pigs that causes a very similar disease to that which is induced by TGEV, but which is not in the United States. Hemagglutinating encephalomyelitis virus, which is an infrequent cause of CNS disease in pigs, and bovine coronavirus. PRCV is most likely a deletion mutant of TGEV, and it has a deletion in the S-glycoprotein gene that appears to have resulted in marked loss of virulence, particularly loss of virulence for an ability to replicate in the intestinal tract. PRCV does replicate in bronchiolar epithelium and alveolar macrophages, and to a limited extent in enterocytes. And isolates vary from non-pathogenic to moderately pathogenic. Probably one of the most interesting aspects about PRCV is that it is widespread in Europe and it appears to have induced herd immunity that has severely reduced the incidence of clinical TGE. TGE is a rare disease in Europe currently, whereas we certainly see plenty of clinical TGE here in the US. And this correlates with the fact that PRCV is much less widespread here than it is in Europe. Clinical signs, this is usually a subclinical infection, but in some herds it can cause mild coughing and dyspnea and be a component of Prdc predominantly in nursery pigs, but also in grow-finished pigs. It's rarely seen alone, so you're unlikely to encounter PRCV-induced gross lesions. But experimentally, it induces a bronchointerstitial pneumonia that is similar to, but much milder than, that induced by SIV. And histologically, what we see is a necrotizing bronchiolitis that basically cannot be distinguished morphologically from swine influenza. There's attenuation of epithelium, infiltrates of mononuclear cells within the bronchiolar wall and extending into the adjacent alveoli, with moderate numbers of inflammatory cells in the alveolar spaces. As with SIV, we have a proliferative phase as well in the subacute phase with hyperplasia of bronchiolar epithelium. Immunohistochemistry will reveal coronavirus antigen within the epithelium of the bronchioles and occasionally within the epithelium in the small intestine. So both TGEV and PRCV can replicate at both sites, but TGEV will cause disease, clinical disease in the small intestine, and this is TGE with villous atrophy and epithelial changes, whereas PRCV will cause lesions that are clinically significant only in the respiratory tract. Diagnosis, nasal swabs are probably the best choice, and you want to use acutely infected pigs for antemortem diagnosis. We isolate a coronavirus and then PCR is performed to differentiate this from TGEV. IHC or FA do not distinguish the two viruses, and serologically antibodies can be distinguished by blocking ELISA assay. The last disease I want to discuss today is Edema Disease, because it's caused by an agent, an E. coli, that produces a Shiga toxin, which is similar to the Shiga toxin produced by OH157, the E. coli that causes the severe food poisoning outbreaks in humans. These E. coli colonize the small intestine, adhere to enterocytes via pili, and these F18 receptors are not expressed until weaning. The toxin, the Shiga toxin X2E, is produced, enters the bloodstream, and causes vascular necrosis and edema. Heat-stable toxins A and B are also frequently produced, and so we get a concurrent diarrhea. This is a disease of post-wean pigs, nursery pigs, in the first couple weeks after weaning. They have eyelid edema and CNS signs. There are often no gross lesions, but if you're lucky, we'll see edema of the subcutis as well as the stomach, mesocolon, and mesentery. Here's a stomach wall that's partially incised to demonstrate the severe mural edema. Microscopic lesions, the characteristic ones are arteriolar necrosis in the intestinal tract and brain. Subacute, there's more of a proliferative vasculopathy. We may see malacia and perivascular edema in the brain, and in the ileum, adherent coccobacilli. Definitive diagnosis requires isolation of the causative organism and demonstration of the typical lesions. And the organism may not always be detectable in the gut by the time that the disease is evident. Histologically, fibrinoid necrosis of arteries. This is the brain, more fibrinoid necrosis, perivascular protein droplets. And here a focus of severe malacia in the CNS. Occasionally we see subacute lesions in the small intestine with proliferative arterial lesions in the submucosa. And here is a higher power demonstrating the hypertrophied cells in the media as well as the endothelium. Hypertrophied endothelial cells and a very edematous arterial wall with hypertrophied cells in the media as well. And so that concludes my comments on edema disease.